Welcome to the deep dive.
Great to be here.
Our mission, as always, is simple. You bring us your source material, could be notes, articles, anything really.
And we help you pull out the absolute core insights. We cut through the fluff.
Exactly. A shortcut to getting properly informed, especially, well, if you're revising.
Which is what we're doing today, focusing on making things high yield.
Yes, today we're tackling childhood eczema, or atopic dermatitis, based on the MSRA pediatric revision notes you've shared with us.
Yes, a very common condition. Really important to get a clear handle on this one for pediatrics.
So our aim is to transform these notes into a clear, memorable guide for your revision. We're sticking strictly to what's in your material.
Sounds good. Ready when you are.
Okay, let's dive in, starting with the basics, the definition. Your notes describe eczema, atopic dermatitis, as a chronic inflammatory skin thing.
That's right, chronic inflammatory. The key characteristics in the notes are itchiness, redness, and dry skin, often in patches.
And it mostly affects kids.
Predominantly children, yes. And the notes highlight a strong link to family history, other allergies like asthma or hay fever, the whole atopic picture.
Right, that connection seems important. Okay, what about how common it is? Epidemiology in your notes.
Very common. Your notes put it at around 15 to 20% of children globally.
Wow, that's a lot.
It is. And specifically around 20% in the UK, according to your source. Another point mentioned is that the incidence seems to be going up.
Increasing incidence, definitely something to note. And when does it usually kick off, age-wise?
Typically starts early. The notes state usually before age 2.
So infancy, early childhood, does it last forever? What about the prognosis section in your notes, the natural course?
Well, there's some good news there. The notes suggest about 50%, so half of children, see a significant improvement by the time they're 5.
Okay.
And maybe 75% show improvement by age 10. So while it can be chronic for some, many kids do seem to grow out of it or see it get much better.
That's quite encouraging. Okay, let's get into the why, etiology. Your notes say it's complicated genes, environment.
Yes, it's multifactorial. The notes point to 2 main underlying issues. First, immune system dysregulation. The immune system is sort of overreacting.
Right.
And second, and this is really crucial, an impaired skin barrier function.
Impaired skin barrier. Okay, that sounds key. And building on that, your notes list specific risk factors.
They do. Things like, well, family history, again, eczema, asthma, hay fever in the family.
Makes sense.
Also a personal history of other allergies. Having dry skin itself is a risk factor.
Just dry skin on its own.
Yep. Then exposure to irritants, think harsh soaps, chemicals. And interestingly, your notes mention urban living.
Urban living.
And also the early introduction of certain foods. The notes are specific about certain foods, not all foods. You can see how it connects back the genetic tendency and then these environmental triggers or factors.
Yeah, that mix of vulnerability and triggers. Okay, so how does this actually cause the eczema, the pathophysiology bit in your notes?
Right, the mechanism. This is really important for understanding it.
Yeah.
Your notes explain that you've got the genetic predisposition, the immune system reacting excessively to things like irritants or allergens.
Okay.
Environmental triggers make this worse. This whole reaction causes inflammation, and the inflammation disrupts the skin barrier.
Back to the barrier again.
Exactly. And a disrupted barrier, well, it just can't hold on to moisture properly, so you get the dryness we talked about.
Which leads to itching.
Precisely. Dry skin itches, you scratch. And your notes really highlight this as the itching and scratching cycle. It's a vicious cycle.
Oh, right.
Scratching damages the barrier even more, causes more inflammation, makes it itchier. It's key to why eczema persists.
That cycle. Got it. Definitely high yield. And it explains the main symptoms. What other clinical features do your notes mention?
So the classic picture is that red, itchy rash, the dry, scaly patches. Your notes mention common spots. Face, scalp, hands, and those flexural areas, inner elbows, behind the knees.
The creases.
Yeah. You might also see thickened skin from all the scratching that's called ligenification, excoriations, which are like scratch marks. And because the barrier's broken, there's a higher risk of skin infections.
And your notes mention something about how the location changes depending on the child's age.
Yes, good point. That's practical for exams in clinic. Your notes specify. In infants, it's often the face and trunk.
Okay.
In younger kids, more on the extensor surfaces like the outside of elbows and knees.
Right.
And then in older children, it typically shifts to those flexural areas we mentioned, plus the face and neck creases. That age variation is a key detail from your notes.
Very useful. Okay, so we know what it looks like, why it happens,
Yeah.
how's it actually diagnosed, does it need lots of tests, according to your notes.
The notes emphasize it's mainly a clinical diagnosis.
So based on looking and listening?
Pretty much. A good history asking about the itch when it started, family history, and a careful physical examination looking for those typical features and distribution patterns.
Right. So when would you do more tests based on your notes?
Further investigations, like patch testing for allergies or maybe a skin biopsy, are usually kept for cases that are severe or don't look quite typical.
And why do them then?
Your notes say the main reasons are usually to rule out other conditions that could be causing the rash, or sometimes to try and pinpoint specific triggers if it's not obvious from the history.
Okay, that makes sense. And speaking of other conditions, let's unpack the differential diagnosis section in your notes. What else could it be mistaken for?
Yeah, several things can look similar. Your notes list: contact dermatitis reaction to something touching the skin. Seborrheic dermatitis often affects scalp, face, more greasy scales sometimes.
Okay.
Psoriasis, often different locations, sharper borders, silvery scales. Scabies, intensely itchy, look for burrows. Fungal infections like ringworm.
Lots to consider.
And the notes also remind us there are other types of eczema, like nummular, which looks like coin-shaped patches, or dishydrotic on hands and feet. So yeah, need to keep those differentials in mind, even though atopic dermatitis is diagnosed clinically most often.
Right. The details matter. Okay, now for probably the most crucial part for revision in practice, management. How do your notes suggest tackling it?
It's a step-by-step approach, really, and the absolute foundation, according to your notes, is basic skincare, the most important thing. Moisturizing, emollients,
How much?
liberally and consistently. Your notes use the exact phrase, large quantities. That's a key take-home. Don't be shy with the moisturizer.
Large quantities. I'll remember that.
Yeah.
What other skincare advice is in there?
Avoiding known triggers, obviously, linking back to those risk factors.
Makes sense.
Some practical tips from the notes. Apply simple emollients before you put on any steroid creams, and a really specific, useful one. Don't scoop creams out of tubs with your fingers. Use a spoon or spatula to avoid contamination.
Ah, a good hygiene point.
Yes. And they also mentioned there are different types, like creams versus ointments, implying choice matters depending on skin dryness or location.
These practical tips are gold for revision. What about treatments for flare-ups?
For flares, when the eczema gets worse, your notes list topical corticosteroids, steroid creams as the mainstay,
Right.
and also topical calcineurin inhibitors as another option, particularly for sensitive areas like the face.
Okay. And I saw wet wrapping mentioned.
Yes, wet wrapping is in your notes. It's a technique where you put the emollient or steroid on, then cover it with damp bandages, then often a dry layer over that. It helps the creams penetrate, soothes the skin, and stops scratching.
Sounds intensive.
It can be, but very effective for some, and for really severe cases that aren't getting better with topicals.
Look good.
Your notes mention that oral cyclosporin, which is an immunosuppressant drug, is an option to consider in those very severe resistant situations.
Okay, so a stepped approach.
Yeah.
Basics first, then topicals, maybe wet wraps, and then systemic treatment for severe cases. Consistency sounds key.
Absolutely. Your notes imply that adherence to the plan is critical for getting control.
Which leads us nicely into complications. Your notes list potential problems if it's not managed well. This really underlines why treatment matters. What are the main ones?
Well, that broken skin barrier and the scratching make the skin vulnerable. So skin infections are a big one mentioned in your notes, both bacterial, like impetigo.
Right, the crusty sores.
Exactly. And viral infections, particularly herpes simplex virus. And a really important high-yield complication your notes flag is eczema herpeticum.
What that exactly?
It's when the herpes virus spreads rapidly across the damaged eczematous skin. It can be quite serious, needs urgent treatment, definitely one to remember from your notes.
Eczema herpeticum. Got it. What else is on the complication list?
The notes also talk about sleep disturbance. The itching can be relentless, especially at night, affecting the child and the whole family.
I can imagine.
There's also the potential for emotional distress, from how the skin looks, the constant discomfort. And finally, your notes bring it back to that increased risk of developing other allergic conditions later, asthma, hay fever, that connection again.
It really does all tie together. The barrier, the immune system, the allergies.
It does. And your notes stress that good, consistent management is the best way to try and prevent or at least minimize these complications.
Okay, so let's circle back to prognosis one last time. We said many kids improve. What's the final word from your notes on outlook, especially considering management?
While the natural course often involves improvement, your notes really emphasize that the prognosis in terms of day-to-day control and quality of life depends heavily on sticking to that management plan.
So managing it well is key, whether they outgrow it or not.
Exactly. It's about controlling the symptoms and maintaining skin health throughout.
Okay, brilliant. We've really gone through your notes quite thoroughly there. Definition, prevalence, the why etiology, risk factors, pathophysiology with that key itch-scratch cycle.
How it looks at different ages, clinical diagnosis, what else it could be.
The management steps focusing on emollients and topicals, potential complications like eczema herpeticum.
And finally, prognosis and the importance of treatment adherence. It's all there in your material.
So the big takeaway for revision.
I'd say understanding those core concepts, the barrier defect, the immune response, the itch-scratch cycle, and then knowing the structured management approach. That's the essence of tackling it based on your notes.
Fantastic. Hopefully breaking it down like this straight from your notes makes it all feel a bit more manageable, maybe even a bit more sticky for revision.
We certainly hope so.
Now, just a final thought to leave you with, something prompted by our discussion of your notes. We talked about the links between eczema, allergies, and environmental factors like urban living mentioned in your material. What further questions does that whole interplay raise for you about maybe the bigger picture of our modern environment and childhood immune health?
Something to mull over, definitely.
Well, we really hope this deep dive into your childhood eczema notes has been useful for your MSRA revision. Thanks again for bringing your notes to us.
My pleasure. Always good to talk through these things.
And just before we go, remember, for more MSRA revision resources, do check out pastthemsesray.com.
And for free resources, head over to freemissra.com.